I'm Ashley and Rueben.
And I'm Ruben Strayer.
And we're here to bring you Road to Resus.
We've got a critically ill patient to manage. And along the way, we're going to encounter a series of clinical controversies, and you're going to hear experts on all sides try to convince you that their position is the right position. And then you're going to have an opportunity to vote on whatever you think is the right position, and then the clinical trajectory of the patient is going to proceed according to your vote. So let's get you ready to vote. Take out your phones, as if they're not already out.
We would like you to go to Slido, SLIDO.com, or SLI.do. Both will get you there. Then you're going to enter code SMAC.
Once you join with code SMAC, you're going to select SMAC day number 1, and you should be on your way. If you have any trouble with that, if you, for whatever reason, can't get this to work, it's not a problem. You can vote with your voice. When the time comes, you can just scream at the top of your lungs, whatever you think is the right choice. We don't want to be accused of any voter suppression here at SMAC. So let's meet the patient.
All right. You've been dispatched to a motor vehicle collision. Upon arrival, you hear blood-curdling screams. It's a woman's voice. The baby! Get my baby! Your heart starts to race. You're rushing. You move back the side airbag. It reveals a woman in her 20s. She reaches for you, startled. Please, please, get my baby! But she's pinned at the waist. So you peer in the back seat, and you see an empty car seat. It looks like there's a snowsuit. So you nod to your colleague to check it out. You tell her, "Ma'am, it's okay. We've got you." She starts fading fast. "Please, just leave me. Please, just get the baby." You look to your partner. His horrified face reveals,
The baby's dead. Mom doesn't know baby's dead. Meanwhile, mom is obviously critically injured, is going to require an aggressive trauma resuscitation. So now we have our first question, our first controversy. You're the lead medic at the scene. Do you tell mom that her baby is dead, that her baby's died, and risk making what's already a precarious patient safety situation even worse? Or do you lie to mom and say, everything's okay, we've got the baby, we're going to reunite when everything's settled at the hospital? No ethics consult, no experts to guide you here, just your gut. Go ahead, cast your vote.
no option 3.
Only 2 options right now.
So your patient is quieting down now. You're increasingly worried. She's hypoperfused. Her pulses are weak. She's clammy. Now we have to consider those gurgling secretions and how we'll manage the airway.
How are we going to manage this airway? What's the right way to manage this patient's airway? Do you think that best practice supports the paramedics right here and now attempting endotracheal intubation, or should they place a supraglottic device, like an LMA, and transport?
We're going to hear from an expert.
Here's our first expert.
Hi everyone, this is Michael Perlmutter talking to you from Minneapolis, Minnesota. I wish I was with you enjoying SMAC, but no time for small talk. We have a critically injured patient who clearly needs advanced airway management. What does this patient need right now? What is our goal? Dash 1A. Coined by Dr. Bill Hinckley, this is definitive airway, syn hypoxia, hypoventilation, hypotension, or aspiration on the first attempt. But we get hung up on the definitive portion. We're obsessed with this, but what if definitive is definitively bad for our patients? One episode of hypoxia or hypotension is associated with higher mortality. To avoid this, we need to replace the relatively difficult, much more likely to fail procedure, endotracheal intubation, with a straightforward, tremendously effective technique that reliably oxygenates, ventilates, and protects just about everyone. Does this patient need intubation? Eventually, probably, but where and when? Oxygenation and ventilation are not best accomplished by attempting intubation hanging upside down in a smashed car. We now know beyond any doubt that supraglottic devices placed by pre-hospital personnel are reliably successful on the first attempt. Patients require much less sedation and analgesia to tolerate a supraglottic airway versus an endotracheal tube. And this is a big deal in undifferentiated hemodynamically marginal patients who are unlikely to tolerate humane doses of any anesthetic agent, including etomidate and including ketamine. Finally, let's talk about aspiration. Pre-hospital intubation proponents really like to focus on aspiration, so let's do it. I'm here to tell you clearly, if we're worried about aspiration, we should be worried about intubation. Browdy and Stewart-Wald's review demonstrated no difference in aspiration between supraglottic airways and intubation. Prospective studies, like PART and Airways 2, found no difference in aspiration between supraglottic airways and intubation. This question has been answered. Are there patients who benefit from the protection an endotracheal tube offers over a supraglottic? Yes, but those benefits have to be weighed against the harms of preparing for and executing endotracheal intubation, and there's a lot of science now telling us the harms of pre-hospital intubation outweigh the benefits. Now, there's no doubt it feels heroic to get that tube into the trachea. It feels good, but here's what's even more heroic. Rapidly optimizing physiology to set your patient up for recovery, and it starts as soon as we arrive on scene. So let's sum it up. Supraglottic airways are easier to place than endotracheal tubes and are more likely to be placed successfully on the first attempt. The simplicity of supraglottics is a huge advantage early in resuscitation when we have numerous urgent and often competing priorities for therapeutic interventions, all while managing complex, dynamic, uncontrolled pre-hospital scenes. Both retrospective and prospective data suggest that there is no difference in aspiration rates between intubation and supraglottic airways. Patients need -1A every time. In 2019, the D in -1A, the definitive pre-hospital airway, is a late-generation supraglottic airway. Give this patient the best chance by providing the best airway management in the field. Supraglottics save lives. This is Michael Perlmutter, signing off.
Thank you, Michael. It's good to hear.
Does anyone out there have maybe an opposing viewpoint?
Yeah, I certainly do. Hello, everyone. My name's Jeff Healy. I'm an anaesthetist and pre-hospital and retrieval physician with Sydney HEMS. I'm also a part-time therapeutic kitten trainer. Just we don't have any at lunchtime, so sorry. So a lot of Mike's points are really valid, but this is an unfair debate. This is just an unfair debate. What's this patient going to get when they get to a hospital? They're going to get a tube. But along with that tube comes the whole package of care. They're going to get sedation, muscle relaxants, definitive airway, oxygenation, CO2 control, and that package of neurocritical care. Why do they have to wait to hospital to get what we consider to be a standard of care? Why can't they get it at the roadside? An LMA is just not going to cut it. I put these in patients all the time. For a patient to tolerate an LMA, they have to have a good suppression of the airway reflexes. They've got to have medication on board. If you're going to put it into these patients in the car, it can cause massive physiological disruption. Why not do it proper, controlled? Like the pre-hospital medical teams and involvements with checklists, well-drilled teams, pre-drawn drugs, and drills to make sure that our first-pass success rate are well above 98%. The -1A stuff is absolutely correct. You don't want to cause hypertension or hypoxia. Do it right. So the debate isn't about tubes and LMAs. The debate is about two things. It's about culture and it's about systems. If your system is not geared up to provide the best level of care, fix the system. The second thing is if your culture accepts a decreased level of care pre-hospitally and you expect to only get that highest level of care at hospital, you need to change the culture. Thank you very much.
Thanks, Jeff. So our patient now...
Yep.
Hold on, you get to vote. Our patient now is peri-arrest and obtunded. Do we use a supraglottic airway or endotracheal intubation?
Time to cast your vote.
Oh, I forgot to vote. Hold on.
I think I know where you're going with this one. All right. Well done. Patient's airway has been successfully managed. She's got a tube or an SGA. It looks like it's going to be supraglottic. So you've successfully put the supraglottic in. Everything, though, otherwise is not going well. She's got a very low end tidal. It's appropriately rising and falling. Her lung sounds are clear to auscultation bilaterally, but she's otherwise quite unwell. She's obviously shocked. Her skin is cold, clammy. Her abdomen is tense and getting a little bit distended. Her radial pulse is thready. There's no blood pressure on the monitor.
So I guess the next question is, do we give her blood?
Do we give her blood? Let's hear our next expert.
Well, we know that keeping our patient warm is important. We know that preventing acidosis is important. We know that preventing coagulopathy is important. Evidence tells us this. In the absence of evidence, we do what we think is the right thing. We do what feels right. We do what seems to make sense, even though there may not be any evidence. So what do we know here? Well, the evidence is poor. Smith did a systematic review in 2016, looking at a lot of pre-hospital blood product papers. Papers like Anne Weaver's in 2013, which showed no survival outcome with pre-hospital blood products. Weaver produced another paper in 2019, again saying that pre-hospital blood products delay the dying process but do not affect outcomes. Shand and Burns have just published in 2019 saying that the evidence is poor, the evidence is lacking. We know that blood products do not improve survival. If this lady is going to die, this may delay it, but it won't prevent it. That's the evidence. But it still seems right, doesn't it? It still seems the right thing to do, to give her this. But that's because we're colourblind. We see red, we see blood. This is not blood. This is a bag of red blood cells. This is a bag of acidosis, stored at pH of 6.7 to 6.8. This is a bag of lactate, of coagulopathy, of calcium-binding citrate. This is a cold bag of viscous red blood cells designed to correct anemia. And it doesn't do it straight away, because 2,3-DPG, 85 to 95% of it is missing in this stored blood. What does that mean? These red cells will not give up their oxygen to your hypoxic tissues for a couple of hours after transfusion. Our patient, she's shocked. She needs volume. She's hypovolemic. She isn't anemic, she has normal blood, just not enough of it. She could perfectly well tolerate a dilutional hemoglobin of 100 grams per litre. Indeed, when we were looking after military patients back from Afghanistan, we deliberately aimed for that less viscous, oxygen-delivering 100 grams per litre. None of these correct clotting factors, none of these are going to stop our patient bleeding. So should we just bang in a couple of bags of the life-saving red stuff? Should we forget about the 90% reduction in 2,3-DPG? Meaning oxygen carriage is minimal. Should we forget about the citrate binding calcium, reducing her myocardial contractility? Should we forget about the hematocrit of 70 to 80%, making her circulation more viscous? Should we forget about the pH of 6.8? Should we forget about the difficulties of cross-matching her when she arrives at hospital, because she may well now have a mixed blood group field? Should we do all of this knowing it's not going to change her chance of survival? Or should we spend the next few minutes concentrating on packaging her, keeping her warm, giving her just enough warm crystalloid to support her circulation, to support her venous return, knowing we are reducing viscosity, improving microcirculation, improving oxygen delivery, and get her to definitive care where we can provide imaging, surgery, targeted transfusion, and critical care as a complete package? I'm afraid that colour blindness means that a lot of us will still vote to give her the red cells. But just be really clear when you do that it is because it's making you feel better. It's not because it's saving her life in the pre-hospital environment. She needs definitive care. So what we should do is concentrate on getting her there. And once we do it, we should be striving to find the evidence. Our patients deserve prospective, randomised clinical trials to make our specialty as safe and robust as all of the others. This may be the right thing to do, but we just need to prove it. And until we've proved it, we need to concentrate on the simple stuff that evidence supports.
I bet we have another opposing audience view.
Yeah, I'm not too far away. Over here. Okay, hello everyone, I'm Brian Burns. I'm a pre-hospital physician. And I just didn't think that the debate was fair without putting up my degrees as well behind me. You know, not many people win the Bunsen Burner Award. Okay, so this patient is exsanguinating. This patient is one of those heart sink patients. This patient is the talk and die kind of patient. She's got hemorrhagic shock, she's got pelvic trauma, she's got a 50% chance of dying before we even get to the hospital, unless we can actually help stop her bleeding, help her blood clot, replace her blood loss, and get her to the point of definitive care. Evidence-based medicine, as Nick says, we should base all our treatment and all our therapies on robust clinical evidence. I'm not so sure about that. I look at evidence-based medicine in a slightly different way. I think evidence-based medicine is judicious use of the current best evidence and applying it to individual patient care decisions. There is good, strong evidence that giving patients in hospital blood products in a 1-to-1-to-1 ratio decrease deaths from hemorrhagic shock. He's right somewhat in terms of pre-hospital evidence is not very strong that we improve long-term or 30-day outcomes, but a bit more on that later. So what we know is, and as Nick says, that giving products pre-hospital does delay the dying process. In pre-hospital care, we are in the game of delaying or disrupting the dying process. It's actually what resuscitation, I thought, was all about. So this patient is on a trajectory towards death. She is not in a warm OR or in a hybrid suite, surrounded by people like Jeff Healy, surrounded by a full trauma team. She is at the roadside. You're there too. She's at the roadside. So why should I treat her any differently on the roadside or on the way to hospital as if I was standing in front of her as a trauma team leader in a trauma centre? It makes no sense to me. Resus wankers, take note. Okay, Nick is right. The packed red cells are coagulopathic. They do contain, low 2,3 DPG levels. God, I could say that. I can't believe I got that out straight. But anyway, the acidotic, all those things. Having said that, if low 2,3 DPG levels were an issue, we would see high SVO2 and venous gases after you transfuse people. We don't, though, do we? And you're all going to look at that next time you transfuse people. We don't. Acidosis in itself comes with hemorrhagic shock. Acidosis switches the curve to the right. People will offload oxygen. He mentioned hypocalcemia as well. Yes, patients in severe trauma, severe shock like this patient do have hypocalcemia. But actually it's independent of the red cell transfusion and calcium chelation. It's poorly understood, but severe shock and ischemia reperfusion causes hypocalcemia in itself. So for this patient, I'm going to give her IV calcium irrespective of whether we give her transfusion or not. I do agree with Nick, we need to look beyond, though, packed red cells. If I could, I would take this patient back in a DeLorean time machine, back to either World War, when we were treating combat casualties with fresh whole blood. This patient is bleeding fresh whole blood, so the best resuscitation fluid for her is fresh whole blood. That feasibility is currently being designed at the moment, but we're not quite there yet. We're getting there. But in the meantime, we do need to look beyond these packed red cells. So along came the kind of trial recently that the evidence-based machine really loves, and that was the PAMPER trial. And that is where patients at risk of hemorrhagic shock were given 2 units of plasma or crystalloid goal-directed therapy. They found that there was a 10% decrease in mortality in giving patients plasma. 10%. And the separation at the Kaplan-Meier curve was at 3 hours. 3 hours. Now, I'm not going to debate crystalloids. Crystalloids are, I won't say it, effing bad. Shit. Yeah. They're really bad. They cause dilutional coagulopathy, they cause hyperkalemic acidosis, they cause ARDS, they cause abdominal compartment syndrome, multi-organ failure, and they cause endothelial damage. And interestingly, plasma also seems to help in terms of endothelium. If there's something going on with plasma, it's not just that by giving plasma we decrease giving crystalloids, we actually have some kind of endothelial protective effect. So it's time for the water pistol. I like my scissors. If you are thinking of voting for death by crystalloid with salt water, please put your hand up now. Oh God, I'm spraying myself. Okay. So if you're thinking of voting death by crystalloid, please put your hand up now. It is warmed, by the way. No one. Okay, I'll sit down. Oh, you want it, do you? Are you sure? Not yet, no.
I think that might be...
Debate. Okay, so we've come to that time. We need to vote soon. We need to get this patient to the trauma centre alive. We need to support her circulation. We need to support her clotting. And we need to stop her dying. We need to give her pre-hospital blood products. We need to give them now. So I hope, like me, you'll see red.
Thank you very much. Now it's time for our last vote of the day.
Voter suppression aside, feel free to vote at will.
Is this lady going to get blood in pre-hospital, or are you just going to transport?
Well, oh, there was 20% of people in here, Brian. You have to find them.
All right, looks like she's going to get blood. So, wrap up day number 1. Sometimes in the pre-hospital arena, crazy moral situations come up, and there's no time to call an ethics consult.
So we've decided today that we would like to use an supraglottic airway, and that's superior in the pre-hospital environment over an endotracheal tube.
And while the data isn't definitive about pre-hospital blood, if you're transporting an exsanguinating patient and you have the capability to give it, please do.
All right, we'll see you tomorrow for Road to Resus Day 2.